start now. So, today we are covering hemorrhoid topics, and this is hemorrhoid topic is very high yield, right? Very high yield, and they are asking usually asking this topic like in every month, but not in November, but I'm not sure. But this topic is very high yield. But other topics like hypercalcemia and hyperkalemia, very high yield. Like they were repeating these two topics, like spontaneous, right? So many times they are repeating. So better we will cover it. Especially I am targeting the March doctors because your exam is coming and you have to give more priority to February topics, right? So that's what nowadays I am very concerned about February topics. So let's start. Let's start from hemorrhoids, right? Hemorrhoids. Sorry. This one. Okay, so this is a question that it was given in the February. Okay, so we will discuss everything about these hemorrhoids, right? Yeah. So what is hemorrhoids, doctors? What are the things that we call hemorrhoids? Hemorrhoids, or we have another names. We call it piles, right? These are enlarged, displaced vascular anal cushions containing a rich arteriovenous network, which are subject to downward pressure during the defecation, right? What are those? these are these are protrusions, right? These are enlarged, displaced vascular anal cushion containing rich arteriovenous network, right? These are subject to downward due to this pressure, right? Due to strain, right? Male. So we have two types. We have internal hemorrhoids and we have external hemorrhoid based on their position. So if it is above dentate line, which separate the anal canal from the rectum and visible with the naked eye. So what are the internal hemorrhoids? So here, sorry, here can you see the dentate line here? This is the dentate line. So above dentate line, we call it internal hemorrhoids. Below dentate line, we call it external hemorrhoids, right? External hemorrhoids. So please keep those things in your mind because sometimes you have to differentiate those things. Okay, so you should know about this dentate line. And so what are the symptoms and how we diagnose internal hemorrhoids? So internal hemorrhoids that mean above the dentate line, right? These are originate above the dentate line. Okay, they are originate about dentate line, but they can be prolapsed, right? They can be protrude below the dentate line, but the origin is always above the dentate line. Okay, remember this point. Otherwise, you can think like, then what about fourth degree hemorrhoids? They are usually outside the anus as well, right? So we are separating them according to their origin. Okay, yeah. Then okay, so internal hemorrhoids originate above the dentate line and have columnar epithelium that is insensitive to touch or temperature, so they are not typically painful. So above the dentate line, what we have columnar epithelium. Usually, columnar epithelium is not very sensitive. Because of that, these internal hemorrhoids, we call them as a non-painful hemorrhoids, right? Non-painful hemorrhoids. Okay, then internal hemorrhoids are diagnosed using medical history and physical examination. Symptoms of internal hemorrhoids include bleeding, mucus discharge, and pruritus. Right? There can be a mucus discharge and bleeding and pruritus, right? Because in internal hemorrhage, we can see bleeding as well. They may or not prolapse down the anal canal, right? They can be above just from just in the original position, or they can be prolapse below the dentate line, right? According to their their prolapsing or their staying in the original place, we have categorized them into grade 1, grade 2, grade 3, and grade 4 hemorrhoids, right? So I'll show. So grade 1 mean there's no prolapse. There's no prolapse here. This is the dentate line. Above it, there's a no prolapse here. No prolapse here. Okay, here. Grade 1 hemorrhoid do not prolapse. So grade 2 hemorrhoids prolapse during the defecation and reduce spontaneously. Here, grade 2 can be prolapsed due to straining or defecation, because of the straining, because of the pressure, because of force, but they can spontaneously can go back. They can spontaneously reduce to their original location. So grade 3, they have hemorrhoids prolapse and require manual reduction. They also prolapse, but they are not spontaneously go back. We have to manually reduce it. Here, sorry. Here, grade 3, there's a prolapse, right? They came below the dentate line due to the prolapse. Then we need a manual reduction, right? We need manual reduction for these grade 3 one. Then grade 4 mean hemorrhoids prolapse and are irreducible. So we can't reduce back even manual, or even we can't reduce it back with the manual reduction. So here it's stay like here. Because of that, this can be sometimes painful. Okay. Yeah. Because it's in the squamous cell layer. The prolapse, right? Okay. So then these are the 4 degrees you should remember. Right. So what is in the chat? Yeah. Okay. Things you should remember. Then you should know about the management of internal hemorrhoids according to their degree. Okay, so tell me, what is the management according to their degree? First degree one. So what is the management for first degree hemorrhoids? What is the management for first degree hemorrhoids? Tell me, doctors. For that, you can use this chart. This is a very good chart. This is from RSCGP guideline. We have mentioned it in the therapeutic guideline as well, but better, this is the easiest one. Okay, this is the easiest one. So, in usually in first degree mean there's no prolapse, right? There's no prolapse. So what we can do? We can do the conservative management, right? What are the conservative management? Under that, we have lifestyle modifications, ensure adequate intake of fiber, non-caffeinated food, avoid constipation, avoiding straining during the defecation, then responding to the urge to defecate and not trying to initiate defecation without this. Okay. Then, what are the other things we can use here? No prolapse, first degree, high fiber diet, and injection. Usually, we are not giving injection actually. Usually, it's always, most of the cases, just lifestyle modifications, right? Yeah. So, then, what about second degree? Second degree prolapse, what we can do? Second degree hemorrhoids. We can do ligation or injection. We can do rubber band ligation or injections, right? Yeah, rubber band ligation or injections for second degree and third degree hemorrhoids and fourth degree hemorrhoids. Almost they are considering for surgery, right? Surgery. Always considering, yeah, surgery hemorrhoidectomy. So think like that. But in some cases, in third degree cases, we can use these Doppler here. Yeah, in surgery, or we can use stapler hemorrhoidectomy or Doppler guided hemorrhoid artery ligation. But mainly just remember like this. Type 1 or grade 1, we can do what? We can do the conservative management. Type 2 or second degree one, we can do the rubber band ligation and injections or sclerotherapy. Usually we call it sclerotherapy. Then third degree and fourth degree always surgery. Remember like that. Okay. I'll explain from the questions. So like that. Okay, then these are the things. Then refer patient who do not respond lifestyle measures and over-the-counter treatment as a gastroenterologist or surgeon will expedite managing hemorrhoids. Specialist interventions for persistent bleeding include rubber band ligation injection, sclerotherapy, or infrared coagulation. Rubber band ligation is less likely to require repeat treatment than other local therapies. So that means rubber band ligation is better than these sclerotherapies, right? Surgery may be appropriate if the internal hemorrhoid cannot be reduced or it's associated with skin tag, right? So you all know about now internal hemorrhoids. So now we have external hemorrhoids. So what are the external hemorrhoid, doctors? They originate below the dentate line and are covered with squamous epithelial cells. Because of that, squamous epithelium is sensitive. Because of that, the patient can feel pain here. Below the dentate line. So we have external hemorrhoids, and the squamous cells layers can be sensitive. So because of that, these are painful hemorrhoids. External are painful hemorrhoids, right? So external hemorrhoid may become thrombos. This external hemorrhoid can be thrombosed sometimes as a result of straining during defecation. A thrombosed external hemorrhoid, or we call it perianal hematoma, appears as an external, painful, tense blue swelling at the anal margin. Here, can you see? This is the exact image. So external hemorrhoids, we have different types. We have thrombosed one. Okay, thrombosed one. Here, can you see thrombosed one? And this is like here blue color swelling. We call it perianal hematoma, but this is not an actual hematoma. Okay, please remember that this is not an actual hematoma, but because of the appearance, we call it perianal hematoma, and the actual name is thrombosed external hemorrhoid. Okay. Yeah, the clot is contained within the endothelial line. Blood vessels is not a true hematoma. So please remember these points, right? Okay, so how we should manage these external hemorrhoids, doctors? What is the management of external hemorrhoids? Tell me.
Mostly they resolves automatically and if we don't if it comes within acute phase within 72 hours, then we can do excision under general anesthesia.
Yeah, good doctor. Thank you. So usually spontaneous rupture of thrombosed external hemorrhages can occur. This may resolve symptoms without requiring treatment. If it is rupture, anyway, it's resolved without any treatment, right? Any treatment. Then pain caused by thrombosed external hemorrhoids begin to settle in 1 to 2 weeks without treatment. Okay, 1 to 2 weeks without treatment. This can still can be spontaneously healed, right? Then the hematoma reabsorb spontaneously, often leave in a skin tag, right? So they are talking about this thrombosed external hemorrhoid treatment, right? Thrombosed one. Then, for patients who present within 72 hours of onset symptoms, severe pain can be relieved by excision of the hematoma under local anesthesia. If the patient present within 72 hours, we can excise it under local anesthesia and we can relieve the pain, right? To avoid recurrence, it's important to excise the entire hematoma, leaving an open wound. Simple incision should generally be avoided because it has higher rate of recurrence and can may worsen the symptoms. My doctors, this is for thrombosed external hematoma. Okay, if the patient needs after 72 hours, what we can do, doctors? After 72 hours, then we can use the conservative management or analgesia, right? Stool softeners, like we can conservatively manage because even though it's external hemorrhoids, it can heal by spontaneously, like after 1 to 2 weeks without treatment, right? Yeah. But if the patient present in within 72 hours, we can exercise it, right? Under local anesthesia. Hope you understand it. Yeah. Okay, we'll do some questions. 42-year-old man present to the GP clinic with 2-year history of intermittent rectal bleeding. He described the painless passage of small amount of fresh blood whenever he passes constipated stool. He has not tried anything to relieve constipation in the past. He has no significant medical history and take no regular medications. He works as an office manager and eats uh, eats a well balanced diet with regular intake of fruits and vegetables. On examination, he appears well with vital signs with normal limits. The abnormality detected are internal hemorrhoids visible just beyond the anal verge when he is trained. Digital rectal examination and proctosigmoidoscopy are otherwise well. Which one of the following is the most appropriate initial management? What do you think, doctors? Type your answers in the chat quickly. What about other doctors? Is it increased fluid intake and stool softness, hemorrhoidal ligation, rubber band ligation, sclerotherapy? What do you think? Okay, here. Patient present with grade 2 hemorrhoids characteristic by protrusion beyond the anal verge, with straining and spontaneous reduction. So, hemorrhoids classified into grades, we know that. Then first line treatment for grade 1 and 2 hemorrhoid is conservative management, increased fluid intake and stool softness, along with dietary modification to increase the fiber intake, can effectively manage symptoms in most cases. Okay, I'll show one more thing. In grade 1 and 2, hemorrhoids should be managed initially with conservative measures include increased dietary fibers and fluid intake. Surgical interventions for hemorrhoids should be reserved for case that fail conservative management or high grades of disease. So grade of hemorrhoid 1 to 5 determine most appropriate management strategy. So here, when we use rubber band ligation, here it's considered for grade 2, okay? They are considered for grade 2 hemorrhoids that fail conservative management. So you can remember like that, okay? Because even though in there mentioned like that, we have to think about like 1 and 2 conservative management. If the lifestyle and modifications and everything fails, we have to think about this ligation, right? Rubber band ligation. But always better to start with. Question is grade 1 or 2. Let's see what they are mentioning in the question. Then we will identify. Okay, here detect internal hemorrhoids visible just beyond the anal verge. That means prolapse, right? Prolapse when he strains. Digital rectal examination and proctosigmoidoscopy are normal. So here it's a type 2, right? He can see this prolapse only when he strains, and then after the digital rectal examination, everything is normal. That means it's spontaneously reduced, right? Yeah, spontaneously it has reduced, right? Otherwise doctor can mention digital rectal examination. The doctor has to reduce it manually like that. So because of that, it's already spontaneously go back. Then it is a second degree one. So how you should remember the treatment, the usual treatment. So you can remember like this. Degree 1, you can use conservative management, especially with fluid intake, stool softeners like that. Okay, so second degree, it still can start with dietary modifications and these other things. Then after that it's not improving, then we can go with rubber band ligation, right? Rubber band ligation or sclerotherapy. But for 3 and 4, we better to go with sclerotherapy. No, sorry, not sclerotherapy, surgery. Sorry. Okay, so we'll do next question. Okay, here 63-year-old man is about to undergo colonoscopy after returning to positive test on screening fecal occult blood test. The patient has no GI symptoms. The photograph shows the view as the procedure is about to start. The lesions are manually reducible. Assuming that colonoscopy is otherwise normal, which one of the following is the most appropriate initial advice to give the patient? So I have marked the answers in here because this is my recall file. So I'll tell the, oh no, I haven't marked it. Okay, good. As I remember, I have marked some questions in there. Yeah, you're lucky. I haven't marked it. So following most appropriate initial advice. So high fiber diet, sclerotherapy, banding, incision and drainage, hemorrhoidectomy. What do you think, doctors? Mm-hmm. What do you think now? Okay, so what is the answer? Okay, grade 3, good. Okay, here. Okay, here. The view shows the partially prolapsed internal hemorrhoid as they are manually reducible. This classes them as grade 3. The grade in hemorrhoids, we know that if the hemorrhoid remains asymptomatic, they should be able to manage conservatively with a high fiber diet. Other conservative measures may include education regarding straining, lingering, yeah, while passing stool, regular physical exercises, avoid medication and food that may cause diarrhea or constipation. If mild symptoms develop, topical agents may be offered. So in this case, if the patient is having any symptoms, it's an asymptomatic patient, right? Asymptomatic patient, and in that case, what we can do, like, can you see? Now you just did the theory, okay? You just did the theory. Then, but you don't know what are the exclusions and what are the key concepts to differentiate it, right? So for that, we have to do the questions, right? Here, yeah, we have to do the questions. Why? If the hemorrhoid remain asymptomatic, they should be able to manage conservatively. Why? This patient is asymptomatic, right? Right? So in that case, so you have another point to remember. If even the patient is having grade 3 hemorrhoid, internal hemorrhoid, and patient is still asymptomatic, we can think about conservative management, right? Because there's no symptoms, right? Yeah. Then, if more troublesome symptoms develop, rubber band ligation should be offered as outpatient. Banding is preferred to sclerotherapy. It has shown more effective. Mhm. However, sclerotherapy should be offered to patients who are antiplatelet or anticoagulation therapy as the bleeding risk is significantly reduced. Yeah, but doesn't have any discomfort. He's just a normal patient, right? Yeah, it's manual reducible. It's not a problem for the patient, and yeah, so it's a symptomatic case. It's no bleeding, no anything. Yeah, doctor. We have to follow therapeutic guide. We have to follow the emails, right? That's what I'm telling because they are given direct questions from e-medicine. So we have to follow it, right? So for the hemorrhoid topics, you should know what are the definitive treatment for each category. Other than that, you should know these exclusions, like special points, and you have to add them into your theory or whatever you are studying, right? Yeah, I like that. Okay, well, that's why I'm telling we have to compare the theory with knowledge, theory with these questions. So, a 66-year-old woman presented to the GP clinic with 3 months history of painful perianal mass. She reports bright red blood on the toilet paper after defecation. Then, and significant perianal discomfort when sitting. She has a medical history of atrial fibrillation and takes warfarin with the target international normalized ratio 2 to 3. She does not take any other regular medications. She reports chronic constipation requiring regular osmotic laxatives. On examination, she appears well with vital signs within normal limits. There are large irreducible congested hemorrhoidal mass protruding from the anal canal. Digital rectal examination revealed single large thrombosed perianal hemorrhoid at 3 o'clock position. So yeah, you saw the answer, right? They are asking the management. 1 minute, yeah. They are asking the management. So answer is excisional hemorrhoidectomy. So patient present with grade 4 internal hemorrhoid characteristic by permanent prolapse that cannot be reduced manually. The presence of thrombosis, chronic symptoms, and significant impact on quality of life indicate the need for definitive surgery. Excisional hemorrhoidectomy is the most appropriate management option for this patient, while it carries a higher risk of postoperative pain compared to the other procedure. It has a lowest recurrence rate and particularly suitable for large chronically prolapsed hemorrhoids. The patient's anticoagulation will need to be managed perioperatively. Hope you understand that those are the main points that you should remember from hemorrhoids. Do you have any other questions? Do you have any other questions? So, what are the points that you can get from these questions? What are the key points that you can get? It's not enough like doing questions and this theory. You should gather all the key points because during the exam week you only need those key points because you don't have time to go through it, right? So tell me what are the key points. You know two types, right? Internal, external, and you should know what are the symptoms. So internal one and external. So how internal present symptoms and how external present. Okay. Okay, I'm not asking from you questions now. Then you should know what are the internal types, right? Then according to the specific grade, you should know the treatment. Like definitive treatment, usually for the first one, conservative. We can manage the second degree. We can use rubber band ligation and a sclerotherapy. Third and fourth, the definitive treatment is, but definitive treatment is the surgery. Treatment is surgery, but when we were doing the question, we gather small specific points. Even though patient is in second degree, we have to start with what conservative treatment. Then, if the conservative treatment is not working, then we can go with rubber band ligation. Okay, if the patient presented with third degree and patient is asymptomatic, so we have to still go with the conservative management, right? Then we all know for the fourth degree and irreducible, so we can't anyway we can do the what surgery, right? Hemorrhoidectomy. So those are the most important points you should know about internal hemorrhoids. So the next one, external hemorrhoids, you should know the symptoms and you should know the treatment. Treatments usually this external hemorrhoid can spontaneously heal, right? But if the patient is presenting with 72 hours of onset symptoms, we can do something to relieve the pain, right? Because it's very painful, right? Why we should keep these patients like in the painful way? We can do something for that. If the patient present within 72 hours, we can do what? We can do the full excision under anesthesia, right? Under anesthesia, if it is more than 72, we can just give the conservative management like pain management, and we can wait it till spontaneously resolve, right? So that's all for the hemorrhoids. Hope you understand. Okay, because much doctors are here, that's the time telling this. During the exam week, those are the points you should know about hemorrhoids, right? In your notes, only those points should be there because you don't have time to go through other huge theory parts. Those are the most important things you should remember. Hope you get it. So we will move to the next one.